Good morning, good afternoon, good evening, wherever you are in the world. My name is Dr. Rachna Shroff, and I am delighted to welcome you all to our next ICRN Translational Seminar Series. And I have the privilege of introducing our speaker today. I'll be moderating the session, and I absolutely encourage this to be a little bit of a dialogue. So if there are questions and such, please do feel free to send us chats or chime in. But today we have a wonderful talk on the role of cytotoxic chemotherapy in cholangiocarcinoma. And this will be presented by one of our thought leaders in that space, Dr. Angela Lamarca, who is a consultant medical oncologist and honorary senior lecturer at the Christie NHS Foundation Trust at the University of Manchester in the United Kingdom. So I would like to hand the mic over to her, and she will walk us through the newest developments in this space. Thank you so much, Angela.
Thank you. Thank you very much for the introduction and also for the invitation to talk about chemotherapy in cholangiocarcinoma. I have prepared a little bit of introduction about the topic, and we will later on go through a lot of detail. And I think we will probably stop during the presentation so we can have a little bit of discussion. So please ask any questions using the chat. So these are my conflict of interest. So I think the first thing I wanted to clarify is about all the clinical trials with chemotherapy and the fact that a lot of these trials have happened not only in cholangiocarcinoma, but also in biliary tract cancer in general. And I think we need to take this into account. For most of the data I'm going to show, there is also some patients with gallbladder cancer and some patients diagnosed with ampullary cancer, not only cholangiocarcinoma. Why is it really important that we talk about chemotherapy and cholangiocarcinoma? Well, this is because even though the precision medicine strategies are really interesting and they are definitely changing the management of all our patients, it's true that this is not the reality for absolutely all of them. And molecular profiling is currently being done more and more in our practice, and we are finding more and more patients for whom a precision medicine approach is possible. But unfortunately, we are having some challenges, and this is not the case for every patient with cholangiocarcinoma. The first reason and the first challenge that we are facing is the fact that not everyone has a biopsy that is good enough for molecular profiling, and we see in our practice that almost 1 in every 4 patients has a biopsy that unfortunately fails testing. The second reason is that even for those patients with a suitable biopsy, for around 60% of the patients, we are not going to find a targetable alteration. That means that even after doing the analysis, we may not really find a treatment that will match that alteration or whatever we find in that tumor's DNA or RNA. Because of this, a big proportion of patients still need chemotherapy options. And in addition to this, it's also true that even though we think that around 40% of the patients will have something that we can target with precision medicine, the truth is that if we look at the latest trials that have been screening patients, we have the impression that these alterations are less prevalent than what we originally thought. And for example, for FGFR2 alteration, looking at some of the latest data, it looks like the prevalence is less frequent, is maybe around 7% instead of around the 15% that what we originally thought. Because of this, it's really important that we develop novel cytotoxic chemotherapy strategies for patients with biliary tract cancer and of course for patients with cholangiocarcinoma. When we talk about chemotherapy, I think it's really important that we make a differentiation between the adjuvant setting and the palliative setting. And I have split my lecture in those 2 sections as well. What you see in this slide is a summary of how the management of cholangiocarcinoma happens. The first question that we will ask in our multidisciplinary meetings is whether the disease is resectable. If we are able to have a curative surgery, then that patient will, after the surgery, be proposed to have some chemotherapy in the setting of the adjuvant treatment, which means that we are trying to cure the cancer, trying to reduce the chances of the cancer coming back. In the opposite scenario, in the right side of the slide, what you have is the scenario when the disease is not resectable, and what we are planning is a palliative strategy aiming to control the growth of the cancer and aiming to, of course, improve survival. And chemotherapy is really important here as well. Because of this, we will be talking about adjuvant chemotherapy and also about palliative chemotherapy, and a topic that is more and more coming in cancer in general, and that is coming also to cholangiocarcinoma, is about the neoadjuvant. Neoadjuvant is that chemotherapy that we may first administered in the palliative setting, but that if we have a good response to treatment and a reduction in size, maybe we move into a curative scenario later on. It's true that neoadjuvant trials are still not fully a reality in cholangiocarcinoma, but I think you will see how I mentioned the neoadjuvant word a couple of times, because it's definitely something that will come in the coming future. So let me start about the adjuvant and what do we know about the adjuvant chemotherapy and cholangiocarcinoma. Well, I did mention previously that a proportion of patients will be able to have a curative surgery. And the main challenge that we have is first the fact that that proportion of patients is small. Only a small proportion are really diagnosed early enough to have a surgery. And the second challenge, even more important, is that even after that surgery, the chances of the cancer coming back, the rate of recurrence is still very high. These are data from previous publications, a review of the literature, but as you see, the relapse rate varies between 42 and 70% between different scenarios. For many years, the evidence supporting adjuvant chemotherapy in cholangiocarcinoma was very weak. Up to 2014, this was the best data we have based on a meta-analysis, and really conclusions were quite challenging. But between 2019 and 2020, 3 randomized clinical trials were presented. The first trial was the BILCAP clinical trial comparing capecitabine versus observation. The second one was the PRODIGE clinical trial, comparing GEMOX chemotherapy, adjuvant chemotherapy versus observation. And the third one was gemcitabine, the BICAT trial comparing gemcitabine versus observation. These 3 studies were all 3 randomized studies after curative surgery comparing an arm of chemotherapy versus no chemotherapy, which was at that time the standard of care. What you see in the second part of this graph is the part B, the data for relapse-free survival and the overall survival. As you can see, the only trial that met significance for relapse-free survival was the BILCAP study, and the median relapse-free survival was superior for capecitabine compared to no chemotherapy. And for the overall survival, again, the only trial that met the primary endpoint was the capecitabine, was the BILCAP clinical trial with superior median overall survival when adjusted for other prognostic factors. And because of this, capecitabine is currently considered the standard of care. The other 2 trials didn't really meet their primary endpoint, and therefore we couldn't really show a benefit from gemcitabine or gemcitabine and oxaliplatin, but we do have data from the BILCAP showing benefit in disease-free survival and also in overall survival in favor of capecitabine. One of the main problems was the overall survival analysis in the intention to treat population, and how the pre-planned sensitivity analysis was significant while the primary endpoint was not significant. But despite this, capecitabine remains the standard of care, and I will show you later which are the ASCO recommendations. I wanted to show you a little bit about the subgroup analysis and how some of the subgroups may seem to benefit more than others, but in general, we actually recommend capecitabine for every patient after the surgery if they have had a complete R0 or R1 resection. The data from the PRODIGE and the BICAT trial, both of them exploring gemcitabine-based chemotherapy, were pulled together in this meta-analysis. And again, they are showing that even when all the patients were analyzed together, there was no really benefit from a gemcitabine-based chemotherapy in the adjuvant setting. So what we can conclude is, after this meta-analysis as well, capecitabine remains a standard of care. This is the slide that I was mentioning previously about the current recommendations from ASCO. This is a snapshot of the recommendations, but is mainly saying that after curative surgery with R0 or R1 resection, adjuvant capecitabine is recommended for a period of 6 months. There is also a comment about those patients with extrahepatic cholangiocarcinoma or gallbladder cancer, that if they have had a microscopically positive surgical margin resection and R1 resection, then chemoradiotherapy could also be considered. What you have on the right side of the slide is really a summary of a lot of unanswered questions that we still have in the adjuvant setting. As I mentioned, there have been a lot of subgroup analysis, and not all the patients seem to benefit exactly the same, but that is still not changing our practice. Should maybe future clinical trials explore different patient populations? How should we define patients that should go for surgery? What are we going to do about targeted therapies in the adjuvant setting as well, whenever those come into the field? So capecitabine remains the standard of care, but a lot of definitely a lot of changes to be made in the future. We need better treatments and a lot of questions to answer. One of the main clinical trials happening in the adjuvant setting at the moment is ACTICA. This trial was a randomized phase 3 trial, first designed as observation versus cisplatin and gemcitabine, because at the time of the design, observation was still the standard of care. But after the BILCAP clinical trial showed the results of the positive capecitabine arm, then the design was changed, and the trial is still recruiting patients to capecitabine versus cisplatin gemcitabine. And it could be that in a few years, we may have the results, and if it is positive, it could be that we change our standard of care. The next section is a little bit more about the palliative setting, but Rosna, I'm not sure if you...
Yeah, I would love to just pick your brain on some of that adjuvant data, Dr. Lamarca. Obviously, I mean, it seems very clear that the BILCAP data is probably the strongest data we have in favor of adjuvant therapy. I would love to hear what you think, you know, in the advanced setting, gemcitabine and gemcitabine platinum has kind of beaten time and time again anything else. And, you know, even like the FOLFIRINOX frontline study in the palliative setting was not as exciting as everybody thought in terms of 5FU based therapies. So what are your thoughts in terms of, you know, BCAT, PRODIGE, why they may have been negative studies, and you know, obviously ACTICA is going to hopefully answer this question a little bit better, but I would just love to pick your brain on that a little bit.
Yeah, I think that's actually a very interesting question, because I think one of the problems we have with the BCAT and with the PRODIGE trial is the fact that they were using gemcitabine-based chemotherapy in the adjuvant setting. And as I mentioned, a very big proportion of those patients were after that having tumor recurrence. So you were in a way with that adjuvant treatment compromising what first-line treatment those patients were having, because they have had gemcitabine-based chemotherapy. If they just finished the adjuvant treatment maybe 1 or 2 months earlier, were you really going to go to a first-line cisplatin gemcitabine? That was a little bit of a controversy, and actually some of these patients moved straight into a FOLFOX chemotherapy maybe, which is not in theory the standard first line. So I think when we are discussing the adjuvant treatment, we also need to bear in mind what we will do in the first line setting. And I will say that that's probably one of the potential explanations. Definitely ACTICA is going to answer some of those questions for sure. So ACTICA is definitely data that we need.
Yeah, no, absolutely. There's actually a question that's been posed in the chat about ampullary cancer and how some people approach ampullary cancer more like pancreas cancer. And so in the adjuvant setting recommend, they wrote FOLFOXIRI, but I'm assuming they mean FOLFIRINOX. So when, if ever, is that appropriate? What are your thoughts on ampullary cancer and how we approach that in the adjuvant setting?
Okay, so, well, ampullary cancer is definitely a very difficult scenario because they are very rare. Our approach is that we usually consider them part of the biliary tract patients for the palliative setting. So in the advanced setting, because these patients were included in the ABC02 study, we usually treat them with cisplatin gemcitabine first line palliative setting. In the adjuvant setting, our practice is totally different. The SPAC4 clinical trial was one of the pancreatic adjuvant clinical trials with gemcitabine, capecitabine, and there was also a subgroup of patients with ampullary tumors. Some of the SPAC4 data are not still available, so we still don't know whether GemCap will be superior to gemcitabine, but there is previous data showing that gemcitabine was better than 5FU. And because of that, our practice at the moment is that the ampullary tumors, they do get adjuvant gemcitabine single agent treatment after curative surgery. That's our practice. I know that is not widely spread and not everyone uses the same adjuvant strategy. I know that a lot of countries consider ampullar as very similar to pancreatic and that they consider other options of adjuvant treatments, but our current practice is capecitabine for cholangiocarcinoma and gallbladder and adjuvant gemcitabine for ampullary tumors.
Yeah, I mean, I think it is a really interesting space. And while there is some provocative, albeit retrospective data, I think another interesting practice that some people employ really is looking at the histology, right? Whether it's a pancreaticobiliary histology versus an intestinal histology, and letting that drive you towards a gem-based therapy versus a 5FU-based therapy. Obviously, no prospective data to support that. It's like you said, it's a little bit of a institutional or just individual bias in terms of how you approach it. But I agree. I think it's an interesting subpopulation.
Yeah, definitely. And that's what I was going to say. You really rely on the expertise of your pathologist as well, because not in every institution they will actually give you that information. Something similar is also, for example, the duodenal adenocarcinomas. Sometimes they respond very well to pancreatic cancer chemotherapy, and sometimes they don't really respond so well. So very challenging scenarios for sure. Do you want me to continue?
Yeah, why don't we keep going a little bit?
Okay. Okay, so I think I will now move a little bit to the palliative setting. So as I mentioned, everything I mentioned previously was mainly adjuvant, and I will now focus for the rest of the presentation in palliative. I have split this in some subsections, but I'm happy to, of course, stop whenever you feel appropriate. We will start with first line. I will mention second line, and I have quite a few slides about second line, mainly because of the some of the most new data has been presented in this setting, and I think it's really important that we put everything into perspective. And then I have a few slides about new drugs, new combinations, and of course some form of precision medicine in inverted commas in the setting of chemotherapy as well. So starting with the first line treatment, as I mentioned previously, is the ABC02 clinical trial. In here, we had patients with cholangiocarcinoma, we had patients with gallbladder cancer, and we had patients with ampullary tumors, included all of them in the ABC02 clinical trial. And because of this, cisplatin gemcitabine is now the standard of care, which showed superiority to single agent gemcitabine in this clinical trial. The primary endpoint was overall survival, but there was also benefit in terms of progression of progression-free survival, and as you can see in the second Kaplan layer. What I believe is really interesting in the first line setting are some of the triple chemotherapy combinations that are coming. To me, the combination of cisplatin gemcitabine and nab-paclitaxel, again, one drug that we very, very frequently use in pancreatic cancer, is showing very promising results. And this is the phase 2 study, including 60 patients, and it's really interesting to see a response rate of 45%, which is superior to what has been described in the past with cisplatin and gemcitabine, for example, in the ABC02 clinical trial. And this is, for example, one of the slides where I will talk about neoadjuvant and whether maybe this triple combination with this high response rate could be one of these schedules to further develop in locally advanced setting when surgery is not possible to start with, but maybe if you have a good response and some reduction, you could be talking about some form of neoadjuvant treatment, and we could move into this kind of staging strategy. There is also promising data in terms of response rate with, again, a triple combination with cisplatin gemcitabine and S1. It's a little bit more challenging to really understand S1 in the Western population, but in this phase 3 Asian study, what we see is, again, a good response rate. This is a randomized phase 3 with a control arm being cisplatin gemcitabine, and as you can see, the response rate was 41.5% with a triple combination compared to 15% with cisplatin gemcitabine, quite similar to what we had seen in the ABC02 study. So again, here I bring up that thought of the neoadjuvant. Again, if we have a tumor that maybe is not resectable at the first diagnosis, triple combination could be of benefit. But I would like to stop in this slide a little bit more, because more is not always better. And I think this is a very, very important message, especially when we are talking about the palliative setting. What we want is to gain control of the cancer, for the patient to live longer, but always keeping a good quality of life and not doing any harm with the chemotherapy. And this is the data from the America trial. This is a randomized phase 2 study, and it was randomizing patients to cisplatin gemcitabine versus FOLFIRINOX in the first line setting. As you know, FOLFIRINOX is a triple combination with 5FU, oxaliplatin, and irinotecan, again with very good responses in pancreatic cancer, in the palliative, and also in the adjuvant setting. So this was some data that everyone was really waiting for, and we were all thinking that FOLFIRINOX was really going to beat cisplatin gemcitabine. But that's not what happened. Actually, as you can see in the graphs, the progression-free survival in the intention to treat and also in the per-protocol population was worse with FOLFIRINOX compared to cisplatin gemcitabine. And as you can see as well, the toxicity was quite significant. So I think we need to be very careful with the triple combinations. Not all the triple combinations have shown a benefit compared to the current cisplatin gemcitabine standard of care, and the FOLFIRINOX data is an example of this. Based on the AMEBICA study, cisplatin gemcitabine remains the standard of care in the first-line setting. I will now move to the second line strategies, and this is the section that is probably a little bit longer, but I wanted to provide a little bit of comparison between some of the data that we already have. So for
Angela,
many—
could I just interrupt and ask a couple questions about the frontline setting first?
Sorry, yes.
So, you know, I completely agree with you. I think it's safe to say that all triplets are not created equal. Do you have any ideas as to what may be driving the differences between, you know, say the FOLFIRINOX data and GemCis or GAP or you know, the S1? I mean, because S1 is still technically a, you know, a fluoropyrimidine, right? So to me, I've had a hard time grappling with, is there some sort of synergy that gemcitabine gives that is different and is needed, if you will, in this biliary cancer population, and maybe even some ideas on how you think we could go about learning. I mean, either through, we know so much now through NGS about profiling and you know, its utility for targeted therapies, but should we be thinking through strategies in all-comer studies of how to better understand what the NGS and biomarker testing kind of does to portend outcomes with GemCis or GAP or, you know, 5FU-based therapies?
Yeah. Well, I hope I had the answer to your question, but unfortunately, I also struggle a lot to understand, for example, the FOLFIRINOX data. I remember when it came out and I was looking at the poster with a lot of detail because I really was not expecting that at all. And I think very much of the FOLFIRINOX data probably comes down to the toxicity. It could be, but you will also expect that the clinicians that were recruiting those patients are clinicians very familiar with FOLFIRINOX, because almost everyone that treats biliary will also treat pancreas. So, you know, I'm not sure about that argument really. I think it could be more linked to what you mentioned about the use of gemcitabine, and maybe there is something in biliary that makes it kind of necessary for the gemcitabine to be present in the first line setting, and maybe that's why we have those very good results with the gemcitabine, cisplatin, and then nab-paclitaxel, which I believe is also well tolerated. You probably know that much better than me, but I think the tolerance of that triple combination was quite good. Was it really different to what you usually see with cisplatin gemcitabine, or how would you compare both from a toxicity point of view?
For GAP, you mean?
Yeah.
No, I mean, you know, there's definitely cumulative toxicities. I mean, as you know, Angela, we do things very differently in the States where we don't necessarily stop chemo after 6 months. And so I think GemCis, I think GAP, I think FOLFOX, I think all of these drugs all of these combinations get hard beyond 6 months. And, you know, the nice thing in the phase 2 is because it was, you know, just Mayo and MD Anderson, there was a little bit of flexibility in terms of how we altered therapies and put people on what I used to call maintenance, where we would drop the cisplatin and, you know, keep the gem and nab-paclitaxel going. There's all kinds of different things. I think SWOG 1815 will be truly telling. Yeah. I mean, so far there's not been any safety toxicity signals that have made us concerned, but I think it'll be informative to really understand what the triplet is. And I think it'll be like the pancreas story, where not everybody can handle FOLFIRINOX, and then the same way, not everybody, if GAP becomes something that we start to utilize more regularly, that not everybody can handle GAP. But there's actually a good question in here about that, about the adverse events. So Dong actually, hi Dong, asked questions about the AEs with GAP and FOLFIRINOX, and I explained how the Asian populations show similar efficacy between all three, between GemCis, GAP, and FOLFIRINOX. And you know, I do think that the AEs, like you said, with FOLFIRINOX they're hard. You know, it's a hard regimen, just like GAP is. And so it does probably impact on efficacy. There's another question in here, Angela, about, does your chemotherapy choice differ between cholangio, gallbladder, and ampullary? Because it sounds like that, you know, the approach is uniform, but I think they're just kind of wondering, do you treat those things differently?
Yeah, so at the moment, we do treat them in the same way. So as I mentioned, in our practice, the ampullary tumors, the gallbladder and the biliary and the cholangiocarcinoma, they are all part of the biliary tract cancer, and we do offer first-line cisplatin-gemcitabine. And also we try to recruit them in the clinical trials, of course, if ampullary tumors are accepted, are eligible. That's our current practice. But again, similar to what we said in the adjuvant setting, we don't really know in the palliative setting. Maybe if we talk more about with our pathologist and if we get that differentiation between whether there is intestinal or pancreatic, maybe our approach will be slightly different, and we probably need prospective studies to look into that. And I would also like to kind of go a little bit back to what you said about the NGS and how that could maybe help in identifying which is the best chemotherapy option for our patients in the first line setting. I don't think we have the answer to that yet, and I don't think it's only NGS. We also need biomarkers in general. We just need predictive biomarkers to know which is the best first line palliative treatment for our patients. And I think some of the translational research that happens with our trials is really important, and I think we need to encourage translational research to happen in every prospective trial so we can learn and answer questions, definitely. I think, shall I continue or do you have more? Yeah.
No, I think let's keep going into the second line.
Okay, so as I mentioned in the second line, I have quite a lot of detail because I wanted to kind of provide an overview and really compare the data with some in-depth comparison. So as I was mentioning previously, it was not up to 2019, we didn't really have a definitive standard of care in the second line setting. Again, we were based on some meta-analysis data that were showing that there seemed to be a benefit from second line chemotherapy after cisplatin-gemcitabine, but the studies were really small, mainly phase 2 studies, single arm and retrospective analysis, and there was no standard of care. The ABC-06 clinical trial was presented in 2019. This was a randomized phase 3 study comparing the arm A, which was the control arm, active symptom control. In this arm, patients were not getting second-line chemotherapy. What they were getting was a very proactive approach with 4 weekly clinical reviews and a very much a proactive identification of any evidence of cancer-related symptoms or any problems with an early intervention about it. So for example, a very good example is the biliary obstruction. Patients, if they were becoming jaundice, they were coming to clinic regardless of symptoms. So we were identifying very starting increasing bilirubin, and there was a very early intervention about that, for example, biliary stenting. In the second arm, the experimental arm was a combination of this acting symptom control, so the proactive symptom management combined with modified, with FOLFOX chemotherapy with oxaliplatin and 5-FU. And the primary endpoint of the study was overall survival. As you see in here, the study met its primary endpoint, and there was a benefit in terms of overall survival in the intention to treat population. You have here the Kaplan-Meier. The hazard ratio was 0.69. One of the problems from the interpretation of the ABC-06 clinical trial was the fact that the differences in the median overall survival were not really very big. As you can see, the median overall survival with active symptom control alone, those patients that were coming for weekly to clinic for symptom control only was 5.3 months compared to 6.2 months for those patients who were also getting the FOLFOX chemotherapy. However, I think for us to understand the benefit from FOLFOX, we cannot only focus on the median overall survival, we need to also look at the 6-month and the 12-month survival rate. And we see how these were improved by 15%, each one of them, and which I believe is much more clinically meaningful than focusing on the median overall survival only. The median progression-free survival was slightly short, it was 4 months, and the partial response rate was 5%. So based on this data and on the improvement on overall survival, the conclusion was that FOLFOX combined with this active symptom control was the new standard of care. I wanted to show you the subgroup analysis because because there was a lot of interest in understanding how the patients with previous progression during the platinum chemotherapy were responding or not, whether a platinum after recent progression to cisplatin was really the right thing to do. And as you can see in the subgroup analysis, the differences between both groups were not really different. And our conclusion is that FOLFOX should be offered regardless of whether the patients were platinum sensitive or not. As I mentioned, based on the ABC06, FOLFOX was at the moment considered a standard of care in the second-line setting. Following the FOLFOX and the ABC06 data, the next trial to report, randomized trial to report in the second-line setting was the RECHIN trial looking into regorafenib. This was not a phase 3, this was a phase 2, but it was randomized with a placebo control. So as we see, 66 patients randomized to regorafenib versus placebo, and the primary endpoint in this case was progression-free survival. As you can see, again, there was a difference in progression-free survival. Again, the difference between both medians is not huge, 3 months with regorafenib versus 1.5 months progression-free survival with placebo. But again, we have a positive hazard ratio, so the trial met its primary endpoint. Unfortunately, this improvement in progression-free survival has not really reflected in an improvement in overall survival, and it's quite difficult to really know which is the real benefit from regorafenib. If we kind of compare the data from ABC06 and the RECHIN trial, I think the first thing we need to acknowledge before we go into comparing the outcome is that the patient population was not exactly the same. In ABC06, all patients were second-line treatment. There was no third-line treatment, which was present in the RECHIN trial. And also, as you can see, the proportion of patients with intrahepatic cholangiocarcinoma is also different. If we look at the outcome data, we see that, again, the partial response with FOLFOX is low. It was 5%, but there were no partial responses at all identified with regorafenib. And we also see how in the RECHIN trial, the median overall survival was 5.3 months, which is the same median overall survival reached with ABC06 in the no chemotherapy arm. It's still quite difficult to really make any conclusions about this, and I think if we compare one trial with the other, what we can conclude is that FOLFOX is the standard of care in the second-line setting, and I think we need further trials and further data with regorafenib to really see which is the patient population that may benefit from this treatment. I would like to stop here slightly to check on what were the guidelines taken back on 2020. So last year, when we had the data from FOLFOX and when we had the data from regorafenib, these were the NCCN guidelines. 2020, they were recommending FOLFOX in the second-line setting as the preferred regimen, and then other alternative regimens were, for example, FOLFIRI and regorafenib. And of course, for patients with a targetable alteration, there was a variety of precision medicine strategies, as I mentioned at the very beginning. The truth is that, as I have shown you, the benefit from second-line chemotherapy for cholangiocarcinoma is quite modest, and we still need better treatment options for our patients. And that's why it's so important that we see new data coming. And with this new data is really what I want to discuss in a lot of detail. So this is the NIFTY trial. It was recently presented in ASCO 2021, a couple of months ago, well, actually 1 month ago. And this NIFTY trial is a randomized phase 2 study in the second-line setting with a very, very similar study design compared to ABC06. So again, second-line patient population after cisplatin and gemcitabine progression. There were 88 patients with NALILI and the 5FU, and 86 patients in the 5FU arm only. In this trial, both groups of patients received chemotherapy. One arm was with combination, the other one 5FU alone. The primary endpoint was progression-free survival, blinded by independent central review, and the data presented in ASCO were per-protocol population. The manuscript is still not available, so the data I'm going to show you is based on that abstract, on that oral presentation during ASCO 2021. The data showed a benefit in progression-free survival, and you see here the separation of the curves in the progression-free survival Kaplan-Meier. We see median progression-free survival 7.1 months compared to 1.4 with 5FU alone. This is the central review data with a hazard ratio of 0.56. The partial response rate was 14.8% with a combination versus 5.8% with the 5FU alone. It's true that this difference did not reach a statistical significance, but the 14.8% is quite impressive, I will say, in the second-line setting. And in terms of overall survival, we have again an improvement in overall survival in favor of the combination of the nanoliposomal irinotecan and the 5FU, with a median of 8.6 months compared to 5.5 with the 5FU alone, with a hazard ratio of 0.68. So what I think NIFTY is definitely showing is that there is a superiority of nanoliposomal irinotecan and 5FU versus the 5FU alone in terms of both progression-free survival and overall survival. And actually, if we look into the outcome from the 5FU alone arm, this is very similar to the active symptom control arm in ABC06. So to me, what we can definitely conclude is that the benefit from monotherapy in the second-line setting for patients with advanced cholangiocarcinoma is not really very much a benefit, and probably those patients are better with no chemotherapy, focusing on quality of life alone, if patients are, of course, understanding what the chemotherapy could imply, especially from adverse event point of view. The very challenging question is therefore to have and put this nanoliposomal irinotecan and 5FU data into perspective with the FOLFOX data. And we cannot forget as well that we have this other group of patients who may be suitable for targeted treatments. And I wanted to kind of compare a little bit the data we have from randomized trials with FOLFOX, with the nanoliposomal irinotecan. We also have the regorafenib, but I'm not really going to go into much detail about that. And of course, one of the randomized trials that we have with targeted therapies, which is the Clarity trial, focusing on patients with IDH mutations. And I have kind of put all these results together in this very big table. And what I'm going to do over the coming slides is to kind of go slowly through the different options, comparing chemotherapy versus targeted, and also the different chemotherapy options between them. And hopefully we can get some conclusions together. So if we go back to the options that I mentioned, we have the FOLFOX and the nanoliposomal irinotecan and 5FU, which I have put in the first two columns. And then we have the regorafenib, which I have, as I have mentioned already, when we compare the regorafenib data with the FOLFOX data, the regorafenib, I believe, needs a little bit more of research still. It's too early really for that to be considered a standard of care in the second-line setting. So I'm not really going to go through that in a lot of detail. And then the last column that I have is the ivosidenib with the IDH inhibitor for patients with IDH mutation. The first comparison is, do we need to go for a targeted treatment strategy if there is a targetable alteration, or shall we go for a chemotherapy strategy in the second-line setting, even in the presence of a targetable alteration? And I would like to give you a little bit of overview of the results. So the first thing that we see, and that seems clear, is the fact that the median overall survival with ivosidenib was 10.8 months, which is the longest that we have with all these 4 studies. But we cannot forget that this ivosidenib trial is definitely focusing on a very specific population of patients, all of them, most of them with intrahepatic cholangiocarcinoma that we know have a better outcome. So I think comparison of overall survival for us to be able to conclude whether we should go with a targeted treatment or with chemotherapy is not really fair. We also see that the hazard ratio with the IDH inhibitor is lower, so this is showing more of a benefit from treatment compared to the placebo, with a hazard ratio of 0.46. But again, we cannot forget that we are focusing on a very, very specific population of patients. If we focus on progression-free survival, the results are a little bit the opposite. We have longer progression-free survival in the chemotherapy trials, while we have a shorter progression-free survival in the ivosidenib trial. But again, a little bit surprising, we have a lower hazard ratio, therefore more of an amount of benefit, more separation of the curves in the IDH population. I think what I will probably conclude here is that both with NIFTY, for example, and both with the ivosidenib, we have good responses in the way that we have long-term benefit with a 22% progression-free survival rate in both scenarios. I think the response rate seems a little bit better with chemotherapy than with the IDH, but we cannot forget that these precision medicine approaches are looking into a very, very specific population of patients. And I think these comparisons are not really fair. Very difficult to make these comparisons, very difficult to make an interpretation on the overall survival and progression-free survival. I think the patient selection based on molecular profiling and whatever access to treatment we have should be really driving our decisions. And we are probably looking into a scenario where patients will end up having everything, having the targeted treatment if that's available, and also the chemotherapy strategies. What is probably much more challenging is to compare the FOLFOX data and the nanoliposomal irinotecan and the 5FU data. And I will try to give you my conclusions from the comparisons that I have been kind of looking into. So if we focus on the estimation on the overall, on the median overall survival, it looks like the NALIRI is superior to FOLFOX. We have 8.6 with nanoliposomal irinotecan and 5FU compared to 6.2 with FOLFOX. And it looks the same if we look at the 6 month and 12 months overall survival rate. But where we are comparing trials, we also need to look beyond the overall survival, the median overall survival, and beyond the rate, the estimation, and we need to focus a lot in the 95% confidence interval, because it's our way of knowing whether one is really superior. For us to conclude that one is definitely superior to the other, what we will expect is for the not to be any overlap between the 95% confidence interval. And I spent some time going through the data. Again, this is the data from the presentation and the abstract only. So this may change from the final on the final paper. But with the data that we have available, we see that there is an overlap, even if the median overall survival looks superior with the nanoliposomal irinotecan and the 5FU compared to FOLFOX, we see that the 95% confidence interval overlap, and the same happens with the 6 month and the 12 months overall survival rate. The estimations may seem superior, but the 95% confidence interval overlap. Actually, if we look at the Kaplan-Meier and if we look at the hazard ratio, which is the way of us measuring how much those curves are separating, we see that the hazard ratio for both treatments are actually very, very similar. And this is probably telling us that the impact on overall survival is probably more similar than what it may seem by looking at the median overall survival alone. If we focus on progression-free survival, we see a little bit more of a difference. Again, we have 7.1 months with nanoliposomal irinotecan and 5FU versus 4 months with the FOLFOX. But again, the 95% confidence interval are overlapping. The only moment when we really have a difference is in the 6 months progression-free survival rate. As you see on the first graph, there is no overlap between the 95% confidence interval. And again, with the 12-month overall survival rate, it seems that the NIFTY is achieving 22% at 12 months progression-free survival rate, compared to 8.6 with the FOLFOX. And again, here we don't have the 95% confidence interval for NIFTY, and we cannot conclude whether there is any significant difference or not, but one may be superior to the other. In terms of response rate, it looks like the nanoliposomal irinotecan is superior, but again, we don't really have a comparison. We cannot really compare both trials in this aspect. So my conclusions about this comparison between the two studies, I think we need to acknowledge that both studies are looking into similar setting patient population, including the rate of, for example, patients with intrahepatic cholangiocarcinoma is very similar. We do need to remember that the ABC06 with FOLFOX is a phase 3 trial compared to a phase 2B with the nanoliposomal and 5FU, and also the fact that FOLFOX was analyzed in the intention to treat population, while the data we have for the nanoliposomal irinotecan, at least for now, is in the pre-protocol analysis. In addition, as I mentioned, we are waiting for the manuscript. So these are provisional comparison only, and they may change if we have new data. And I also wanted to mention that for in the NIFTY trial, they had a very different progression-free survival estimation for the nanoliposomal irinotecan by central review than by the investigator. And actually, in the central review was the 7 months that I have been showing, which was the primary endpoint and the data that I have shown you. But if you look at the presentation from ASCO, you will see that in the investigator assessment, it was, I think it was it was less than 4 months, it was 3-point-something months for progression-free survival. So there is a discrepancy there, and it's actually in the opposite direction. Usually we will expect for the investigator to be more optimistic than the central review. This is probably something that we need to understand a little bit better. I think numerically, if we focus on the median overall survival and the punctual estimates, it's true that overall survival and progression-free survival seem superior in favor of nanoliposomal irinotecan, but we cannot forget the 95% confidence interval and how they overlap, and also the fact that the hazard ratio for overall survival is very similar between both studies. My conclusions is that in order to really show superiority of the nanoliposomal irinotecan and 5-FU versus FOLFOX, we probably need a head-to-head comparison study. I do believe that these two treatments are complementary, similar to what I mentioned with the targeted treatments. We probably want patients to have exposure to all of them. I think they complement each other and that they are not really competitors. And of course, we cannot really recommend which one to use at first. It's very unlikely that a sequencing trial will happen, and we probably need to be driven probably by adverse events. For example, if you have a lot of toxicity, neuropathy, for example, from previous platinum, maybe oxaliplatin cannot be administered. I think the take-home message is definitely the benefit of the 5-FU-based chemotherapy and definitely the benefit of a combination over monotherapy. I don't think the benefit seen in the 5-FU arm is enough for us to consider monotherapy treatment. And of course, understanding better how the platinum resistance may play a role. There is a lot of translational research ongoing with ABC06 that we will hopefully have the results soon, and we will probably or hopefully try to understand better which patients do really benefit from FOLFOX, and that could also help to understand better which patients to use for FOLFOX or for nanoliposomal irinotecan and 5-FU. I think the future of the second-line trial with second-line setting, we definitely need more treatments. We know that there is a good correlation between overall survival, response rate, and between overall survival and progression-free survival, and we know this from previous meta-analysis. And we, most importantly, also know that phase 3 studies are feasible. And we don't only have ABC06, we also have clarity showing that phase 3 studies in the setting of a very niche patient population of a rare cancer are possible with the adequate network. Because of this, we need more phase 3 studies, randomized, and with a primary endpoint of overall survival, or maybe progression-free survival in some specific scenarios. Maybe when we know that the patient is going to have multiple subsequent lines of treatment, when overall survival then is difficult to be a primary endpoint. The next section are about the new drugs and new combinations. So maybe we can stop here a little bit, and if we can go through any questions before. The next sections are much shorter.
Yeah, no, that's perfect. So there are actually a couple questions in the chat box that are actually more related to some more targeted approaches and such. But one question, so I'll kind of save that for maybe a little bit later when you get to the newer drugs and combinations. But there is a question about how you approach treatment of what they call collision cancers, but I think they mean kind of a mixed HCC cholangio, and if there's a different approach there for therapies.
Okay, well, again, a very, very challenging question. And actually, I don't think we have any answers for that. I am actually not aware of any prospective data. So I think the best data we have is from some registries, which of course there is a huge selection bias. What I usually do in clinic is to be driven a little bit by the clinical picture and also by the tumor markers. And I know in the era of precision medicine, this may sound a little bit silly, but actually when you have a pathology and a biopsy of a mixed cholangiocarcinoma and hepatocellular carcinoma, if you have a rise in AFP, maybe going for an HCC-based treatment makes sense, while if you have a rise in CA19-9, maybe you are more trending to go into more of a cholangiocarcinoma type of treatment. Another option is to try and understand which is the representation in the biopsy. Is there majority of HCC or majority of cholangiocarcinoma? And maybe use that also for your treatment strategy. I hope I had an answer to that question, but I don't think it's not even in the literature.
I agree. Those are incredibly challenging cases for sure. And then, I just had a quick question. I want to make sure that we have time for you to finish your subsequent topics, but just in terms of the second line setting, there was that data looking at FOLFIRI, like not NALIRI, but FOLFIRI versus FOLFOX, which of course was, I think at ASCO the year prior, maybe GI ASCO. And again, they seemed somewhat equivalent. So I think all of your points are incredibly well taken. None of these have been compared head to head. We don't truly know. It does seem that combination therapy is better. But would you say that it's possible that we can, maybe sequentially use all of these therapies, keep them in
Yeah,
armamentarium, irinotecan, oxaliplatin, et cetera?
Yeah, definitely. I think we will probably move a little bit into the colorectal arena where you use FOLFOX and then FOLFIRI. And then, I think it's about utilizing all the treatment options that we have and making sure that our patients get access to every treatment option. That's why I don't think we need to make a decision between targeted or chemotherapy. Is about using one after the other. And I see FOLFOX and FOLFIRI or nanoliposomal irinotecan and 5-FU in a very similar way. Is probably about using one after the other, and utilizing all of them, of course, if the patient is fit and is well enough for it.
Perfect. All right, let's make sure that we get to all these other exciting topics.
I think I will go through the next 3 sections, and then we have some a little bit of discussion at the end. These are the shortest. So I wanted to have these sections about new treatments and new combinations, because I think it's very important that we know that the field is moving forward. And I know that we are talking about cisplatin, gemcitabine, FOLFOX, FOLFIRI are type of chemotherapy that have been used in cancer for many, many years. But it's important to see that there are new drugs coming also for rare cancers, for example, like cholangiocarcinoma. So we have the NUC1031. This is like a new form of gemcitabine. We had promising data from the ABC-08 clinical trial, again with a very high response rate, 43%. And this drug is now combined with cisplatin, being developed in the first-line setting with a new type 1:1 clinical trial, comparing cisplatin gemcitabine versus cisplatin and NUC1031. Again, another new drug is this new form of etoposide, and there is a small phase 2 clinical trial, very small and very difficult to really see whether this efficacy is enough for bigger clinical trials, but very good to see that new drugs are coming to the field. New cytotoxic chemotherapies are also being developed for rare cancers, like, for example, cholangiocarcinoma. Regarding new combinations, immunotherapy is very, very interesting in a lot of cancers. And in cholangiocarcinoma, it looks like the combination of immunotherapy strategies with cisplatin and gemcitabine is promising, and is more promising than using immunotherapy on its own. And because this, again, very good to see that a lot of clinical trials in the first-line setting are comparing cisplatin gemcitabine versus cisplatin gemcitabine combined with immunotherapy, and definitely looking forward to the results of those trials. A lot of them are randomized. New drugs, again in the immunotherapy setting, and again combined with chemotherapy. We have this new compound, which is a fusion protein anti-TGF-beta and the PD-L1, and is in the first-line setting now being compared in a phase 3, a clinical trial, to cisplatin gemcitabine on its own, or cisplatin gemcitabine combined with a bintrafusp alpha. So again, very important to see that there are a lot of clinical trials in the first-line setting. We need to bear this in mind when we see these patients in our clinics, to make sure that we are exploring trial options for them, because a lot of interesting trials are happening. And it's not only immunotherapy with chemotherapy, there are also triple combinations about comparing the immunotherapy, combining the immunotherapy, chemotherapy, and also TKIs. And we see here, for example, very impressive results from this quadruple combination, including also a TKI into the combo with immunotherapy and chemotherapy. And of course, precision medicine strategies, we have mentioned them. I was, for example, talking previously about IDH, and I will now mention about FGFR. As you know, there are a lot of FGFR inhibitors, and a lot of these are now being combined, are being compared to cisplatin and gemcitabine. But it is very likely that in the future, some of these precision medicine approaches may be combined as well with chemotherapy. And the same could happen also for the IDH1 inhibitors that we have available. So combining precision medicine approaches with chemotherapy is probably going to come in the future as well. Very briefly, I have mentioned we need predictive biomarkers for chemotherapy. And this is what I called here the precision chemotherapy approach. And I'm only going to give a very, very quick example. But for example, we know that if we have a deficiency of the DNA damage repair mechanism, like the DDR, then we know that this is present in around 15 to 20% of patients with biliary tract cancer. And we know that in the presence of DDR, it may be that the disease is more sensitive to platinum-based treatment. Actually, there seems to be a better response with platinum chemotherapy in the presence of DDR, even though the impact on progression-free survival and overall survival is a little bit challenging to understand. As you see here, it looks to have a benefit in overall survival and progression-free survival, while other studies are not really showing that. But definitely very important as part of that NGS that we are doing for molecular profiling, looking into whether there is something that could maybe let us know that the patient could be more sensitive to oxaliplatin in the second-line setting, for example, and that could be very interesting. And this is my last slide. I think cytotoxic chemotherapy remains the most prevalent treatment option for patients with cholangiocarcinoma. In the adjuvant setting, as I mentioned, capecitabine for cholangiocarcinoma and gallbladder, gemcitabine, as we mentioned in the discussion for ampulla, that's our current practice, but I know it's not widely accepted in every country, so that may change in your clinic. The palliative setting in the first line is cisplatin and gemcitabine, and in the second line we have had the option of FOLFOX from the ABC06, and now the latest data from nanoliposomal adenotic and 5FU, and definitely coming some neoadjuvant strategies, basically because of this very impressive partial response rate that we see with some, not only, of the triple combinations. Remember the negative data from the FOLFIRINOX and how not always more chemotherapy is better. Cisplatin gemcitabine superior to FOLFIRINOX. And finally, the new drugs and combinations that we really need with chemotherapy strategies as part of them, and predictive biomarkers that will probably let us know which are the best treatment for our patients. And this is my last slide. Thank you very much for your attention. And I think we can go, I think we have a few minutes, 5 minutes, maybe 4 minutes more.
Yeah, no, that's great. Thank you so much, Dr. Lamarca. There is another question in here, and again, this is a little bit more about precision therapy and targeted therapies, but somebody would like to know how you are approaching HER2 amplified or mutated biliary tract cancers and what data we have in that space. I know that that's a talk in and of itself.
Well, it's another topic, but so I think the data is interesting, but it's still not really, I will say, as strong as it is for other precision medicine strategies. Having said that, if there is a trial available, I will definitely recruit the patient in the trial. So there have been some basket trials with HER2 inhibitors for patients with HER2 mutations, and there were some cholangiocarcinoma patients and responded very well. And there are also ongoing clinical trials for HER2 amplified biliary tract cancer. We know that usually the HER2 amplification is more frequent in extrahepatic and gallbladder, less frequent in intrahepatic cholangiocarcinoma, but I will definitely encourage the recruitment into these clinical trials. If you have the access to a HER2 inhibitor in your practice and the patient has a HER2 amplification, then again, I think it's about making sure that the patients get access to as many treatment options as possible. And it's true that the data may not be as strong as for EGFR inhibitors or maybe the IDH inhibitor, but in the presence of a HER2 amplification, I think if there is access to treatment, those could be utilized. But again, I think larger trials are required really to understand the benefit.
And then I'll just ask one last question here about the perioperative neoadjuvant space. You suggested that perhaps some of these triplets could have some utility in downstaging. Do you think we should start, to your point about how a lot of us who treat biliary cancers also treat pancreas cancer, do you think we should start thinking through kind of pre-operative therapy for even resectable, or should we start thinking about borderline resectable as our chemotherapies and cytotoxic therapies get better?
So I think that's probably going to be the future. And it's true that in pancreas cancer, it has taken us some time to really start talking about borderline resectable and being comfortable with the neoadjuvant setting and the perioperative chemotherapy. And now we are much more comfortable with that. And I'm sure it will happen in biliary tract cancer as well. That's why I think these triple combinations are really promising, because the same way that we utilize FOLFIRINOX a lot, and now more also gemcitabine for borderline pancreatic cancer, I think some of these triple combinations could be really promising. And I'm sure our multidisciplinary teams are going to be using borderline resectable biliary more moving forward than what we do at the moment, definitely.
All right. Well, thank you so much, Dr. Lamarca. I'd like to thank everybody for your participation and your engagement. She's very kindly shared her email here, so don't hesitate to reach out with any other additional questions. But thank you all so much for joining, and thank you, Dr. Lamarca, for a very fantastic and comprehensive talk.
Thank you for the invitation. My pleasure.